story in a second. Okay.
Time 2:56.
Thank you.
Hey, I thought it was okay.
You ready? Yep. 1, 2, 3.
Epi, going in now. 2:58.
They have to get his heart beating again.
No pulses. Resume compression.
Still bagging, okay.
I'm gonna get set up for a central line.
All right, still bagging, all right.
Great. Why don't we pause for another rhythm check? You can intubate.
Opioids and the crisis that we have currently in our nation begins ultimately many times from patients that are going to pain clinics, or they're post-op pain, or they're having routine procedures, and then things go awry, things go wrong, they're predisposed, other reasons, and then they have opioid issues. But we do know treatment with opioids long-term reduces longevity of life.
The experience I've had with older adults has been primarily in an opiate treatment program that I worked in during fellowship at a VA medical center. And there's kind of been different waves or different generations of opiate use disorder. The older population that has an opiate use disorder, for 20 years, tended to start their opiate use disorder journey with heroin, and the younger crowd, the newest wave of people with opiate use disorder, 80% of them started their journey with a prescribed or illicitly used prescription opiate.
Drugs gave me some relief to other pains that I were feeling in my life that I didn't know how to deal with. I think like many people in our culture, when I was growing up, nobody really cared about how you felt. You were told to hide your feelings, mask your feelings, suck it up, be a man or be whatever, And it seems like from the moment I could talk, they told me, shut up and listen. We don't care about your feelings, go to school, get out of here and get a job. The world doesn't care. Nobody cares about your feelings.
I was like maybe 17, 16, something like 16 or 17, when the average person was smoking marijuana, taking Red Devils, Quaaludes, and stuff like that, drinking. I started shooting dope, straight up, I started drinking wine to start shooting dope. Because, like I said, the role models that I had, everybody was shooting dope. So that's where my really experience started.
Well, I think there's a lot of stigmas attached to substance abuse disorder, but it's not just that. I mean, it's not just the people with substance abuse disorder. We have a long way to go in medicine to understand our own feelings. So that could be the person's economic situation. It could be their skin color. It could be their religion. It could be their country of origin. I think as physicians, we walk into a room and sometimes in our mind there's a judgment.
Just say that a methadone program is around the corner. Just say I don't have this on. I have an old pair of pants on, a dirty pair of tennis on, and a t-shirt, right? And I go in there to get my Met, that drank Met, on the clinic. I drank that, pay $15 a day so that I won't use that day. now. Another person, a lawyer, in his three-piece suit, briefcase and everything, can go in right behind me and drink his meth. The stigma will be more on me because of this is a lawyer, a white lawyer, dignified, real sharp, about the 500 suit on, $1,000 gator shoes on, and a $1,000 briefcase, and going to drink the same methadone that I'm drinking, and we doing it for the same reason. Except for, you know, the stigma, because what I got on is a stigma on me, but it's all right, it's cool because he don't have that.
Substance use is definitely a hidden epidemic in the population, and it's hidden for, I'd say, a common denominator between younger and older adults. There's denial associated with it and stigma that prevents people from understanding and recognizing that there might be a substance abuse or misuse problem. The other thing that's happening that's unique to old age is there's an assumption that they're more likely to lose orientation. So I think if somebody loses cognitive orientation for a while, they will not assume that it was because of an alcohol or a substance use problem. They might assume that they are getting Alzheimer's or some kind of dementia, or some kind of medication isn't interacting correctly. Or if somebody had a fall, they would assume it's some kind of frailty instead of a substance use problem.
It's really important to not be judgmental. It's really important to listen with empathy and respect. It's important not to oversimplify what is going on in their lives. You know, substance use is really complex. People's motivations for use is really complex. Genetic factors, such as people's personality traits, people that are sensation-seeking or highly impulsive. On the other side, people that are prone towards negative thinking or anxiety are more at risk for substance use disorder. And then, of course, trauma. So adverse childhood experiences are highly predictive of substance use disorders. Sexual trauma, especially early childhood. And then, you know, what's going on in the community, what's going on in the environment matters as well. So what are community attitudes towards that substance use? What does parental monitoring look like? Do parents know where their children are? What does availability of different substances look like in different communities? So all of those things kind of go into the general risks. It's important to understand that that substance use might be a solution for that person, not just a problem. You know, you're seeing all of these problems potentially associated with their use, but this is their solution.
Abstinence alone, abstinence as a cure for substance use is not going to work. It takes counseling, it takes intervention, it takes support.
Nobody with a substance use disorder is excited to have it. And if there were good options for them, without stigma and without the judgment, and without fear of being arrested, I think we see a lot more people trying to access what we have.
A culture of recovery or a recovery-ready community is a community that when somebody reaches out for help, we know how to get them the help, that we feel responsible for getting them the help.
The treatment research around older adults is that they need geriatric psychiatrists trained to work with older adults, understanding the medical morbidities associated in old age to treat them. And older adults actually like to be treated around other older adults.
A life is a life. It's not to be overshadowed by anything. So harm reduction in that world is saving a life from potential harm. The spread of disease, the spread of infections, all of that is harm reduction. Am I going to be able to get any of these users into a program? I would hope so.
Recovery is a long-term process, so we know it takes a great deal of time for people's brains to heal. So just because they haven't used in 30 days doesn't mean they're all better.
I think life was intended to have ups and downs. But because you're down, don't mean you can't rise up, you know. And I think for myself and a lot of people choose to, when they fall, they choose to stay there. Recovery gives us that ability to realize that, hey, we can rise and fall and rise again. And that the only barriers in our life really are the ones that we self-impose. When we start to realize that others have placed barriers or, you know, obstacles in our life, then we're also in a position where we can decide to remove those. That's our responsibility then, you know? And that's what recovery to me is. Recovery is living a full, joyous life where the sky's the limit.